Hi, everybody. Good morning, good evening, good afternoon, wherever you are. I'd like to welcome you to the IACH Journal Club. We are November 19th, 2020, and for this new Journal Club, it is my great pleasure and honor to welcome Professor Stephen Gouill from the University Hospital of Nantes in France, and Professor Christian Gisselbrecht from the St. Louis Hospital in Paris. And as you may guess, these are two top experts in the field of lymphoma. So our topic for today is about mantle cell lymphoma, based on a very recent paper published in the Lancet Hematology. But before going into the details of the article, I'd like simply to remind those who are just joining us what is the goal and spirit of this journal club that we have launched a couple of months ago. I think everybody's convinced that the medical literature is growing and we need a critical evaluation and appraisal. We need to expand and balance each physician's scope, because at the end of the day, we would like to encourage and favor good clinical practice and state-of-the-art patient care. So how this can happen? One way is through a journal club where I will present a summary of a chosen paper, and then I will initiate the discussion. So Professor Gouill is the first author, and Professor Gisselbrecht did not participate actually to this work, and both of them will try to enlighten us about the value and content of this article. So the article that was chosen for today's journal club has been published on the 7th of November in the Lancet Hematology. And you can see the title, Molecular Response After Obinutuzumab plus High Dose Cytarabine Induction for Transplant-Eligible Patient with Untreated Mantle Cell Lymphoma, a phase 2 trial of the LYSA group. So this is the summary of this paper that you can easily see in PubMed, and the conclusion of the authors is that obinutuzumab plus DHAP is a well-tolerated regimen and has a good activity for inducing MRD negativity in the bone marrow of these transplant-eligible mantle cell lymphoma patients. Let me walk you through 1 minute into the procedures, then we can understand easily the debate and the context of this study. It is a prospective, open-label, single-arm, phase 2 trial, which investigated obinutuzumab plus DHAP. I think most of you are familiar with DHAP, in untreated patients with mantle cell lymphoma eligible for intensive therapy. So the treatment included 4 phases: induction, consolidation, maintenance, and post-maintenance. The induction consisted of 4 cycles of obinutuzumab plus DHAP before auto transplant, followed by obinutuzumab maintenance, then obinutuzumab on demand for MRD positive patient as post-maintenance. Interestingly, in the single-arm study, the primary endpoint was MRD negativity in the bone marrow after these 4 cycles of obinutuzumab plus DHAP at the end of induction. And you can see on the table 2 of this study in the paper that the MRD negativity in the bone marrow as assessed by qPCR is really very impressive using this combination. And another feature of this paper is that they have also compared bone marrow to peripheral blood. So I'll stop here and now give the floor to our panelists and to discuss with them. So first of all, thank you both for joining us. And maybe I'll start with the first author of the paper, Professor Gouill. Before going into the details of the study, Stephen, can you just remind us what is the standard of care for induction in a mantle cell lymphoma today, young and fit patient eligible to intensive chemotherapy?
Thanks, Mohammed, and first of all, thanks for selecting this abstract for this discussion. So the standard of care, if we all of us are based in Europe, so I will first start with the ESMO recommendation. For the transplant-eligible patient, it's the standard of care is high-dose RSC containing regimens before transplant, followed by rituximab maintenance. So the induction there is a clear benefits to add high-dose RSC in the induction. So there are different regimens. Here we use RDAP, but you can use CHOP-DAP or hyper-CVAD if you want, which is not very familiar in Europe. But RDAP or alternative CHOP-DAP, or another one is called the Nordic regimen, is high-dose RSC and CHOP-like treatment. So this is very similar. So these three regimens are quite standard of care, and followed by the transplant. And for the conditioning regimen, it used to be a TBI-based regimen, but it's not already the case today. We all prefer to use a full chemotherapy regimen like BIM, which is a popular regimen. And after the transplant, there is a clear demonstration that the rituximab maintenance, one infusion every 2 months for 3 years, provide longer disease control. So this is very simple. High-dose RSC, auto rituximab maintenance.
Professor Gisselbrecht, you are on the same line?
Almost, but I just want to remind the audience that, in fact, everything started with the high-dose RSC. And in the state that was MD Anderson with hyper-CVAD, without transplantation, and in Europe, and especially in France, that was with a DAP regimen. And all the other country group at that time would rather use a CHOP regimen. But with the CHOP regimen, we had a very high rate of relapse after the treatment, and we have to find something. So the first attempt was to consolidate what you can get with your chemotherapy first with a stem cell transplantation. And so the Lima group started a lot of study, step by step, trying to improve and to see what is the best for the patient. And I guess the finding that they could improve not only the complete remission for the patient before transplant, but to improve also the percentage of MRD negative patient was a major advance for that. And then you can build on that and see what you can do with that.
Excellent, thank you very much. And here I would like to remind our audience that they can send their questions or comments through the questions panel or through the chat. And I'll be more than happy to share them with our two top experts. So I'll stay with you, Professor Gisselbrecht. What is your take-home message from this paper? I will not ask the question to Stephen because he has been leading this work and obviously he may be biased, but what is your take-home message?
I will have two ways to look at it. One is with this regimen and this monoclonal antibody, we have a fairly high response rate in terms of MRD negative. Now, when I look at their own data from the past, from the Lima study, I am not completely convinced that they made a lot of progress by shifting obinutuzumab when they were using rituximab before. And the response rate is maybe slightly superior, but it's not a randomized study. So I am not fully convinced that we have to change some old rules that we established, than Stephen established some years ago. I want to be straight.
So, Stephen, so I know the goal of the trial was about MRD as assessed in the bone marrow or peripheral blood. But then one may question, what is the value? What about PET scan? I mean, I'm not a lymphoma expert, but I thought that in the lymphoma field, we mainly rely on PET scan. Is this something that we should not consider anymore based on these MRD data?
No, definitely not. PET scan is a very interesting tool in lymphoma, and one should not be substitute to the other. One marker should not be substitute to the other one. In mantle cell lymphoma, it's probably one of the lymphoma entity where we have not so many data about PET scan. We perform an ancillary analysis in the LYMA trial where we showed that PET scan was predictive of the outcome of the patient. But it's not like in DLBCL where we are really convinced, or Hodgkin lymphoma, that PET scan is today able to drive the medical decision, which is not the case in mantle cell lymphoma. So I will invite you to watch the ASH meeting. There will be a very interesting talk by Mary Callanan. She perform the MRD study in the LYMA trial, and we look at the impact of PET scans. It's not a front-to-front comparison, but there are very nice data about how these two methods can be combined together to have a better vision of the outcome of the patient. So today, PET scan is highly used in lymphoma. In mantle cell, there are a lot of things to do before to use it as a guideline, and there are more data about MRD by PCR techniques, in fact. So this is why we choose MRD.
Okay, so you have just, mentioned diffuse large B-cell lymphoma. So maybe I can ask a question to Christian. Why do you think obinutuzumab looks to be highly effective in mantle cell lymphoma as we see in this trial, while I remember, I think it didn't prove to be highly effective in DLBCL? Do we have any explanation?
Well, the mechanism of action is slightly different, and obinutuzumab is focusing on the DCC and maybe have more immunologic component behind. And the toxicity is a little bit higher than rituximab. So it's effective, but now to prove that it's better than the other, you cannot show it. And your large randomized study, the Gouill study, could not demonstrate any type of benefit. And you can see that even in low-grade lymphoma, the benefit is present, but it's not a major one. So that's a new drug. We can be used in several types of lymphoma, maybe not all type of lymphoma. But I want to come back to this problem of definition of remission. And we can see that with the technology, we move at the beginning with the clinical data, with a CT scan, then the PET scan, then with different type of measurement of residual disease from TI, from the now cytoflu, droplet, qPCR, and even I look in the abstract book this afternoon, I don't know what are the results. Some are looking at the circulating tumor DNA. And one of the reasons for that is in mantle cell lymphoma, that's not completely a leukemia. And the fact to have some circulating cell, depending on the type of mantle cell lymphoma, can be predictive of the outcome or not. And one of the questions I will ask to Stephen, do you think it will be active in chronic mantle cell lymphoma, SOX11 positive, for example, this approach, or because we are not facing a problem of complete remission, they can survive more than 10 years?
Yeah, I think the case of indolent lymphoma has to be treated apart from the other one. And in fact, because we don't really need to treat this patient and wait and watch remain standard of care, I think all these methods really do not apply to this entity. I just want to go back to Christian's comments. I fully agree with him about the fact that this study does not demonstrate that obinutuzumab is superior to rituximab, and we should now use obinutuzumab. This is clearly not the end point of the trial. It's interesting to keep in mind that before this LYMA trial, there is only one trial that is reporting interest of obinutuzumab in mantle cell lymphoma. It was published by Franz Mauchauser, and there were only 15 mantle cell lymphoma treated with obinutuzumab. These were the largest series of mantle cell lymphoma patients treated with obinutuzumab, at least monotherapy. So what we learned from the LYMA 101 trial is that obinutuzumab can be added to DAP, which has never been shown before. It's a new regimen somehow, and this that it's feasible, not more toxic than DAP. And interestingly, this provides a high response rate at the molecular level. And maybe some of you remind that 3-4 years ago at ASH, I showed some results about the molecular response after RDAP and the complete remission rate in the bone marrow after 4 courses of DAP for 64%. These data will be updated at ASH in the talk of Mary Callanan. So I'm not, I just encourage you to watch it. But it was 64% with RDAP. We do exactly the same thing. It's not face-to-face, but we go up to 75. So let's say that we reach our goal in the phase 2. It's not a demonstration that obinutuzumab is superior to rituximab, fully agree. But let's say that there is this is an indication that maybe obinutuzumab can be a mantle cell lymphoma drug, while it's not a DVL BCL, and I agree with Christian, it's working in follicular lymphoma, but not that high. And just one more comment about the mechanism of action. You ask why obinutuzumab will be better in mantle cell or not, we don't know. There is another mechanism of action of obinutuzumab that is different to rituximab. It's a BCL-XL action. Obinutuzumab can downregulate BCL protein expression. And BCL-XL is one of the major drugs to protect the mantle cell from apoptosis. So by deregulating BCL-XL down, obinutuzumab has a mechanism of action that is important in mantle cell, which is not the case in the other lymphoma entity. So maybe this is also another rationale that will encourage the use of obinutuzumab, but fully agree that today the LYMA 101 trial is only a phase 2 and should not be seen as a phase 3.
Okay, so here we have a lot of questions. Unfortunately, guys, I'm not able to take all the questions that are coming into my dashboard. So I'm trying to put them together. Otherwise, we can spend the whole day or night on this. But we have lots of questions about the treatment. And in general, I can summarize that in the hematologic community in general these days, there is a sort of a push against the old-fashioned high-dose chemotherapy, you know, the conventional auto transplant. And I know, Professor Gisselbrecht, you are a pioneer among those who established, you know, the value of high-dose chemotherapy. So what are your thoughts today in a, let's say, 62-year-old gentleman or lady with a mantle cell lymphoma receiving the attractive Le Gouill and colleagues regimen obinutuzumab plus DHAP, achieving MRD negativity, but also negative PET scan? Let me push you. Would you feel comfortable in such patient to say, maybe we can postpone or simply cancel auto transplant and move to maintenance, for instance?
Well, that's a very good question, and we may have the answer in 2 weeks about that, looking at the data of the long follow-up of the LYMA. When I am still supporting the consolidation with autologous stem cell transplantation, it's a black and white result. And for me, when I push that type of technology in all type of lymphoma, it was to have a plateau after the treatment. And so the patient candidate to that are the patient with evolution of the disease. For the chronic disease, it was disappointing. We did that for follicular lymphoma, but it was disappointing. So at the present time, this treatment is still providing a very high response rate with a long duration. And I remember the beginning when I had to explain to this patient, now we will perform in mantle cell lymphoma stem cell transplantation. I cannot tell you the result, but I am pretty confident that it will last. And I am still happy to see that now that I am not in charge with this patient, that they are still surviving. So that was really my thought at that time. Now we can do maybe better with or the same with other approach. I am not sure that we can really do better if we want to cure and keep the MRD negative for a long time. That's an open question.
So here, Stephen, I have another question to you, or maybe you want to comment on this one. Please do.
Well, I'm quite online with Christian. I think we all want to have new treatment that are the more active as possible. And if there is something better than transplant, I'm sure that even Christian will be supportive for something different than a transplant. The fact is that today it's impossible to answer to this question without taking a risk to reduce the efficacy of the treatment. I would be happy to say, yes, you can stop and start a maintenance because your patient is MRD negative or the PET scan negative. There's no need for the transplant. But today we don't have any proof about this. And I think it's important to keep the standard of care as long as they are standard of care. So we need a clinical trial that will compare MRD-driven strategy versus a no MRD strategy, or maybe standard frontline versus a new drug. Because the big things here in mantle cell, which is different from DLBCL, we have very active oral drug targeted therapy, like to use a common name, which is not the case is all the other entity. We got the BTK inhibitors, the PI3 mimetics drugs, and this is new tools that seems very active. Are they more active than a transplant? That's an open question. But today, as a clinician in my daily and routine practice, standard of care remain autologous stem cell transplants remain the backbone of the treatment.
So I'll come back to these new fancy, highly effective molecules, and we will talk about maybe the future chemo-free regimens, I would say. But here, you know, the International Academy for Clinical Hematology is attendance from more than 100 countries across the globe. And we have a couple of questions about those patients who are not transplant eligible, or if you are in a situation where you don't have access into a transplant center. So do you believe that this obinutuzumab DHAP regimen can be also a standard good regimen in the elderly? I'm not talking about the 85 or 90 years old patient, but let's say a fit 72-year-old patient. How do you feel? And not willing to go to transplant.
Well, I think we should forget about today about obinutuzumab in particular, because there is not approved in mantle cell anyway. So in the world. So once again, I believe it's a very good drug in this disease, and there are rationale to use it, but rationale need to be proved by real science. For patients who are not transplant eligible, the standard of care is R-CHOP or BR, and BR is very popular in a lot of countries. In France, we've got some restriction about the use of BR frontline, but BR or R-CHOP are the standard of care. And after R-CHOP, at least, the recommendation is to use a rituximab maintenance. So I don't think that for the non-transplant eligible patients today, there are other options, but there are very interesting ongoing trials that are currently challenging CHOP and BR. But today, let's be standard of care with BR or R-CHOP and rituximab maintenance after R-CHOP. We're trying to we built a study in the LYSA group with the collaboration with our friend of the MCL network. We compare R-CHOP to R-CHOP alternatively with low dose RSE. So, and we will see whether or not there is a difference in terms of response. This low dose RSE is only 1 gram per meter square of cytarabine and not 2 grams like in the DAP regimen. So we're trying to use RSE. Another regimen is BAC. It's bendamustine cytarabine combining regimen plus rituximab coming from our Italian colleagues. Results are interesting, but it's quite a toxic regimen if for the frail patients.
Stephen, to come back to this problem of maintenance, not do you think that the place of obinutuzumab can be in the maintenance when you use one monoclonal antibody at the beginning, that's less toxic, and then you will use another one. And I know that this debate of maintenance in mantle cell lymphoma is quite often brought by the community and say, well, we don't have to do that. We just have to wait to see if they relapse or not before giving them some monoclonal antibody. What is your feeling about that?
Well, I really think it's quite hard to not to give CD20 antibody maintenance rituximab. So this is in the ESMO guideline. It's also on the NCN guideline, and it also written on the MD Anderson's guideline after the transplant, at least rituximab maintenance 3 years. So it's not a never-ending maintenance. And the question might be, if you're MRD negative before the transplant, you get to the transplant, so you're still MRD negative. Do you really need a maintenance? You will have the answer in 2 weeks. Sorry to repeat, but this is something I don't want to reveal everything, but these are very interesting results. I'm sure will convince you. And this is not only a PFS benefit for the transplant-eligible patient, it's an overall survival benefit at the time we perform the analysis. So I'm strongly advocating in favor of the rituximab maintenance in mantle cell. No doubt about that.
So speaking about MRD negativity, we had a few questions, and maybe you would like to comment on this, because in this trial, you have compared bone marrow versus peripheral blood. And we know, I mean, although we hematologists are quite familiar with bone marrow, but I think majority of the patients don't like, to have a bone marrow aspirate frequently. So can we rely on peripheral blood for measuring MRD in mantle cell?
I think there is no human being on earth who like to get to a bone marrow aspirate, and so blood is much more easier to manage. It's a question here because we're talking about the trial and the publication is why we use beyond the bone marrow and not blood. Because there are no clear demonstration that one is better than the other one. But it's more challenging to get MRD negativity in the bone marrow than in the blood. The percentage of bone marrow negativity in the blood is around 64% in the LYSA trial, and it's quite similar with the other trial using RC, while it's 75, 80% in the blood. So we put ourselves in a position where it's more difficult to reach MRD negativity in the bone marrow. So the trial was more challenging by having an MRD negativity in the bone marrow rather than in the blood. So this is also why we choose this endpoint, to put ourselves in a more difficult position. And we succeed finally because we get 75% MRD negativity rate. But the question of the blood, we will compare and look at the outcome in this trial, and we do it also in the LYSA trial. And I hope that blood will be more predictive, which will be good news for the patient. One more thing I want to highlight, because maybe some of the people in the audience are looking at the percentage of MRD negativity in this trial versus this trial. Take a look at the way that we assess the MRD negativity before to conclude. Here, it's an intention to treat, and not based on the patient who at least received the treatment. There are a lot of publications about MRD negativity in mantle cell lymphoma, and you see high percentage. But sometimes, and more often, this percentage is a percentage of MRD negativity for the patient who received the full treatment. So you don't have the patient who were primarily refractory because they don't reach the full treatment. Here, it's not the case. This is 75% intention to treat in the MRD evaluable patient at baseline. So it's also another challenge, and this is something I want to push in the mantle cell lymphoma community, is to assess MRD negativity the same way, and the best way to assess it is intention to treat. It's not at the end of the game and looking at what percentage of negativity there is, which will be too easy.
No, we fully agree, and this is why actually we're organizing these journal clubs, because obviously the devil is always in the details, and I could clearly understand from the discussion of the paper that the literature usually is overestimating the MRD negativity, whereas this trial is more realistic and even compared to the literature may have underestimated, but roughly this is a baseline. So let me be provocative and ask one question, and maybe I didn't read it well, but my understanding that obviously the follow-up was relatively short, less than 15 months, but that was enough to assess your primary endpoint. But I thought that the only patient who had progressed during the follow-up was the MRD negative in the bone marrow and peripheral blood. So you're laughing, Professor Gisselbrecht. So I probably I read it well.
Yes, you read it well. But I say, well, they wanted to show their primary endpoint, which was what's happened before transplant. And because it was described that it was a major issue. Then after that, you have the follow-up, of course. And at that time, when you wait a little bit longer, I am pretty sure that this positive patient will relapse. But that was a funny point, a funny finding.
Yes.
But tell us now that you have the update if they relapse.
So I hope,
what
Stephen,
I
you
plan to
managed to
do,
salvage this patient, I hope.
Yeah, what I would like to, what I will do, it's not that I would like, but I will do it in 1 or 2 years, is to compare and to have a matched analysis between LYMA, which is with the rituximab versus LYMA 101, and see front to front, at least the best way I can do it, I agree, is not front to front, the phase 3, but to match the patients and look at where the different, but we need a longer PFS to do this. Looking at MRD is one endpoint, is an information, but it's not as strong as PFS, and I fully agree that we need a longer PFS than what we publish yet. But we wanted to show that we reach our endpoint, and not that we got a rationale to maybe use obinutuzumab more in mantle cell, and somehow to stimulate the company that is selling the drug to tell them, well, maybe you should try another entity. Well, it's always so. This is one point on my side.
No, very well taken. Very well taken. We have a question here from a colleague, I believe this is Dr. Ramadan, asking, what kind of regimen would you advise in a young patient who is under dialysis?
Under dialysis?
Yeah.
Dialysis. Well, you can use cytarabine, high-dose cytarabine.
Okay.
I will not use blood.
Maybe bendamustine also, which is a drug you can use with patient. If you have dialysis anyway, it's quite it's open. I have one patient, one case was dialysis in Alport syndrome, with a mantle cell lymphoma. It's kind of a not very lucky guy, and he is dialysis, and I treated him with BR, so was well tolerated and good efficacy. Of course, not transplant. Doesn't make any sense for this patient, but I use BR. This is a one case, right? I don't have so much of these patients.
Yeah, but definitely this is useful. I think sharing experiences can be always useful to some patients here and elsewhere. So now we're reaching the last part of this journal club, and I would like to ask both of you, maybe trying to speculate on the future. So my first question to you, Christian, is if you have to design, I'm pushing you a little bit because I know you're very keen and you explain nicely why we should stick to high-dose chemotherapy. But assuming today, given all the available options we have, what would be the most promising chemo-free regimen you would think of to give to a patient, you know, because we have obinutuzumab, rituximab, ibrutinib, and many other actually candidates. So if you have to design a phase 2 trial to test.
I think you have many phase 2 trials ongoing at the present time to see the result. With the data that Stephen produced and the Lima group, if we want to speed up the research and not wait 10 years before getting the result, we have to focus on the beginning of treatment and to see if they have MRD negativity. And if you could find a good regimen able to control the disease and to have a nice percentage of MRD negative, at that time, I guess you can, in a randomized study, play the game of giving the treatment for a long time, chemo-free. But I put my cap of regulator, so-called, sometimes looking at files for drugs, you have to make a randomized study to prove that, and I think it will be very important. One was built, you know, in maybe I don't know, Stephen, how many patients are in this study trying to answer that with chemotherapy and ibrutinib plus or minus transplantation, and that's the way to go.
So, Stephen, my question to you is based on everything that you already did, and you have been really a key leader in pushing forward this mantle cell story. And I can recall that over the last 10 years, I think we've seen some really impressive changes in the natural history of this neglected entity in the past, I would say. So what do you feel the trial we need to run in order to upgrade even the outcome and cure more mantle cell lymphoma patients? What would be your, if someone is giving you now $1 billion to run a superb trial, which one are you going to run?
Vaccine.
A vaccine against mantle cell. Yeah, well, it's very fashionable these days.
Well, I know you're always looking at the publication and you're always up to date, Mohammed. So I'm sure that if you have a look in PubMed and put my name on it, you will see what is my favorite regimen. We just published in Blood, a triplet combination that is highly active. And that will be another reason for invite me for a nice discussion with you. These triplet regimens combining ibrutinib, so BTK inhibitor, let's say BTK inhibitor plus BCL2 targeted therapy like venetoclax, and I think a CD20 antibody, which is active in mantle cell. This triple association or combo is for me very attractive. And I once again agree with Christian. It's interesting to see that it works, but it's not a proof of efficacy. And this regimen, triple combination or doublet, if you only use ibrutinib and venetoclax, now should be compared to a full chemo standard of care regimen to really demonstrate that chemotherapy works, but it's nowadays a standard of care. But it's very challenging to do so. Let me remind you that for me, there is one very interesting trial going on today, which is called ENRICH. It's ibrutinib rituximab versus R-CHOP or BR. It's for first line. It's a UK and Nordic country driving trial. And this is really a trial that can put ibrutinib rituximab frontline instead of chemotherapy. How to do it in transplant? Let's say that the work is in progress and we should think about this. So today, for me, the good directions to go to is the triplet combination. But I'm a very conservative guy. You know me a little bit. I like to demonstrate things before to use it in daily practice. And and this is not cheap drugs too, right? So it's also our duty to prove things before to say to the payers, you should pay this because it works. We need to prove first that it works. So triple association will be for me the top one. You can really
absolutely. We are absolutely on the same line, and we believe in evidence-based medicine, despite the skepticism, I would say, and the environment. But we are strong supporters of evidence-based medicine, and I fully agree with you. It is our moral duty also to make not only effective and successful regimens, but to push to make them accessible and affordable and available to the majority of patients. Your thoughts, Christian, on the favorite combination of Stephen and the future of mantle cell?
No, I agree in some way. I saw that several phase 2 are ongoing, starting with a chemo-free regimen and maybe shifting to more chemotherapy, but less intensive than the DAP regimen and better tolerated. And I think we have a lot of possible combinations, but as you know, they are moving at the same time than research, and we didn't speak about the prognostic factor, the different subtype of mantle cell lymphoma, how to identify the patient relapsing early or late. So I guess we will make progress like that. And if we make progress in the next 10 years, as we did in the past 10 years, it will be really great.
Just to
Well,
give you one short flavor of where the LYSA group is going next year with mantle cells. So we're building, and we will do a randomized trial that will compare rituximab ibrutinib to rituximab ibrutinib venetoclax frontline. So we're ready to do it next year. So doublet versus triplet. They're for patients over the age of 18 with no age limit above, and we will compare these two regimens. So it's a very attractive. This is the first fully chemo-free regimen. I would have liked to compare to the chemo, but some trials are really ongoing. And I mean, the aim of a group like the LYSA is to be more advanced and to propose a very innovative trial. And this will be a LYSA study with our colleague in UK. So it's a France, Belgium, and UK trial. And next year we will have our first patient in.
well, I think this is really fantastic. I would like to thank both of you for really an exciting and lovely debate. I'm very grateful on behalf of the Executive Committee and Scientific Steering Committee of this journal club. I'd like to thank you, Professor Gouill and Professor Gisselbrecht, for sharing your knowledge and wisdom with us. I'd like to thank our audience. I do apologize, we're not able to answer all questions or mention all comments, but you've been absolutely terrific. So wherever you are, thank you for joining this journal club. Please stay safe and keep well, and hope to see you very soon for another IACH activity. Thank you very much and take care.
Bye.
Okay, so
Should we start another round?
no, I think you did very well, guys. I think it's really an exciting.
No,
Okay,
we can close it.
let me stop the broadcasting. We're broadcasting live. Everybody's recording, but we do broadcast live, actually. Okay, wonderful. Anyway, thank you very much. À bientôt, les amis. Merci.
À bientôt. Merci à toi, Mohamed. Bye bye, Christian.
Bye bye. À bientôt.